Rapidly progressive
Right.
glomerulonephritis. This is an important topic both for the clinicians as well as internists as well as for the nephrologist. Because what we see in critical care specialists actually here in Calcutta and elsewhere, the patient when he comes with a so-called pulmonary renal syndrome, they come with a respiratory problem and they come with a renal failure. Often we diagnose as them as a sepsis and acute kidney injury, but in fact they are basically presence of the vasculitis. They have a vasculitis, they present with the respiratory renal syndromes. And they to pick up the vasculitis as a cause and the rapidly progressive renal failure is an important diagnostic tool, and it needs a help from the nephrologist. Not only you have to take the biomarkers, for example, you have to check the NPOPR3 as well as anti-GBM plus ANA profile and so on. But also often you need a kidney biopsy and rigorous, looking for the urine for the red blood cell casts. So that will give you the diagnostic clue in a given patient with a rapidly progressive renal failure. Often we miss actually. If nephrologist is not involved, many patients we find that the patients has been diagnosed as sepsis and acute kidney injury, and they have gone unnoticed, and much later we find a diagnosis of a vasculitis. So I think over to Professor Pinaki Mukhopadhyay to unveil the how he approaches his cases and what is the there are often they come with the mild cases, so it's easy to diagnose in them. But when the patient comes with a florid case, it is often misled. So with this, I'll hand over to Pinaki Mukhopadhyay to have a long deliberation in the Sunday morning. Thank you, Pinaki.
Yeah. Good morning, all. Thank you, sir, for the kind introductions. And Professor Pahari actually discussed the things very rightly, because many of our patient comes either in a day-to-day practice in clinically very mild symptom. Sometimes patient comes with a florid picture. Sometimes patient comes in a very deteriorating state that with a distress, pulmonary hemorrhage, or patient with dialysis dependent. So when the patient needs some transplantation as well. So I will just touch upon uh, all these things, small one. So before starting the main topic, so what is a renal failure? So the renal failure is basically the three types. One is the acute renal failure that occurs in the hours to days, that is less than 2 weeks. And sometimes when this renal failure persists for any reason, it is not resolved, and it is a persistent and persistent more than 3 months, it is become the chronic renal failure. But in between this acute is actually the main challenging, and there is actually the clinical emergency in a nephrologist point of view. So in acute renal failure can be diagnosed in the different way. Whenever the serum creatinine is more than 0.3 within a 48 hours, or there may be a much more 1.5 times increase from the baseline level, even in the urine volume, when it is decreased in the tune of 0.5 ml per kg per hour, that is causes the acute renal failure. But if you continue and if you monitor this patient and if you see that is it is not being responded either in the fluid management or the intervention of the etiology, but it is a persistent, then it is actually persistent of the GFR less than 60 more than 3 months. It is actually the chronic renal failure. So in between this group, which is remain in the 2 weeks to 3 months, that is actually the main chunk of the patient that is sometimes is not properly diagnosed. And if it is not diagnosed, the CKD progression is going on. The patient is lands in the ESRD and needs the dialysis and the transplantation. That group is called the rapidly progressive renal failure. So it is a heterogeneous group of patient and real renal emergency is there. So it is our challenge to diagnose early and take intervention and as well as to take therapeutic management properly and monitoring the system to redress the cause and to reduce the progression. So RPRA, that is the rapidly progressive renal failure, it is basically the three broad heading. That is one compartmental is, if I find it out, one affected is the tubulointestinal component, one component is the glomerular as a whole, or there is some vascular component. So whenever the glomerular is involved, whether in the mesenterium or in the your capillary wall, so this is called the RPGL. That is the most challenging part of the patient comes with the nephrotic or pure nephrotic or overlap syndromes. The when this tubulointestinal component is actually involved in the form of acute tubular necrosis, acute tubular interstitial nephritis, or sometimes of myeloma kidney, the also they will present as a progressive renal failure. Sometimes it is mostly involved with the vascular component that is much more concentrated in a atherosclerotic disorder, renal vein thrombosis, and thrombotic microangiopathy. That is in a more prevalent in the child is a hemolytic uremic syndrome, or even in the adult also, that is the HUS and TTP is the chunk of the patient which is mainly involved in the vascular component. So for the approach to a patient, the first important is the history. History is the key point to find out the actual cause and the organ involvement, and also the to find out whether it is a pulmonary renal syndrome or it is a differently there is a any infection related ATN or AKI. So first you have to find out that is a any kind of the duration of renal failure, whether it is a very short duration or it is a prolonged duration, or is the baseline creatinine is already is there. So it is very important to categorize who is the AKI, RPRA, or it is a acute on chronic CKD. And you have to find out the history. So any history of hematuria, frothy urine, presence of the oliguria, anuria, or the creatinine is actually progressively increased or not. And that is give you the whether it is AKI or it is a CKD or acute on chronic or it is a RPRM. So it is a very important in the first step of the diagnosis in this type of patient. On detailed history, you have to find out the systemic feature to find out the organ involvement. So you have to look for our history, that is presence of hemoptysis, long-standing asthma, or then if petechiae is there, or any feature of the vasculitis is present or not. You have to find out in history that is there any arthalgia, oral ulcer, photosensitivity that is much more indicative of the lupus, or presence of backache, fractured bone pain, or there is elderly age group, albumin, globulin mismatch that is giving rise to the clue for the multiple myeloma. Or you have to same way you have to find out the acute insult cause, that is any fluid loss, hypotension, sepsis, or the presence of any diabetes and hypertension. So all this the basic history that will give you the clue for the renal failure and the associated organ involvement. So in physical examination, the very simple physical examination give you the clue for the diagnosis. Whether presence is pallor, the suggestive of the CKD, the pressure is the normal, that is maybe in terms of TMA, or the high BP in the elder, that is a young age group. That is a secondary hypertension. That is maybe some clue to the renal artery stenosis or the vascular component. And important is that the patient having any oral ulcer or the butterfly rash or any kind of petechiae or is there, that also will give you the clue for the any vasculitis or the any lupus nephritis. Respiratory involvement give you clue for the Wegener granuloma, that is a or choke stress like asthma, sinusitis, or any kinds of pneumonic patch or alveolar hemorrhage. Peripheral neuropathy also sometimes it is associated with this vasculitis and the unrelated vasculitis. So you have to very carefully examine is there any loss is there or not. And after this history and the physical examination, you have to send very simple test for the complete blood count. That is, if there is a leukocytosis, that is indicated for the sepsis, vasculitis, or thromboembolic disorder. If there is a eosinophilia, that is in point towards the Chuksa syndrome. If there is a low platelet, you have to be very careful whether we are dealing with the hemolytic uremic syndrome or not. And most important is that there is a, if the peripheral smear shows that is the fragmented RBC. So it is actually basically the glomerular disease, and so it may be a glomerular cause or maybe some TMA as well. And urine is very important for the nephrologist point of view, and as well as the clinically diagnose the patient. In case of the glomerular disease, there is a dysmorphic RBC, and there must be active sediment. That is a very important clue for the diagnosis of the RPGN. So whenever the patient comes with the active sediment, with the deterioration of the GFR, young age group or elderly age group, so it is a very much clinical emergency. You need to take care very rigidly, and even you have to do biopsy to address the actual diagnosis. So the patient need to have whether RBC is there, is a, any RBC cast is there, if there is a proteinuria, if there is proteinuria, what is the amount of the proteinuria, and what is the type of proteinuria, whether it's a glomerular proteinuria, tubular proteinuria. So it is also important for your actually pathophysiology and pathogenesis of the particular disease. Regarding the RBC, it is also the isomorphic RBC. There may be a eosinophilia. Sometimes ATIN or AIN is there. Eosinophilia, though not very characteristic, but may be found in some cases. So, and another important thing is the amount of the urine protein. That is, whether it is a nephrotic proteinuria, whether it is a subnephrotic proteinuria. That will give a clue for the actual diagnosis. So this is that point, how it looks like. So if you see, that is two important things. One is bright field macroscope. It is called bright field macroscope, and this is a phase contrast macroscope. So in the bright field macroscope, you see there is an isomorphic RBC. It is maintaining the shape of the RBC. But when it is a dysmorphic RBC, in the bright field, even in the phase contrast microscope, if you see the outline is changes and there is a lot of different spaces there. So dysmorphic RBC seen in the phase contrast microscopy is the hallmark or the sine qua non for the glomerular injury. So this is very important for the diagnosis whether the glomerular pathology is there or it is a combination tubular glomerular or simply the tubular. So along with this, the investigation, if some reports comes, hypercalcemia, that is will be targeting to this sarcoidosis or the myeloma. If the LDH is an increase in the TMA, low complement is a sign for the post-streptococcal glomerulonephritis, lupus nephritis, or the cryoglobulinemia. And if the ESR is high, so you have to do SLE or vasculitis. And most important, the viral marker need to be checked all the patient, because hepatitis B, hepatitis C, both can give rise to the membranoproliferative glomerulonephritis, and they can present it as either vasculitis or present as a proteinuria patient, or suddenly along with this liver involvement, they also kidney involvement is there. So it needs to be check the hepatitis B, hepatitis C, and HIV where it is required for all the patient schedule. And chest X-ray need to be done to exclude the any cavities, nodule, or any chest involvement. So some tips regarding the diagnosis, that is patient need to be addressed as a myeloma of the elderly patient. There is a disproportionate anemia or AG ratio is altered. So you have to send the myeloma panel. If the patient is USG QOB done, if it is small contracted kidney, definitely give rise to the CKD. But if the cortical echogenicity is not raised or mildly raised, so it is very likely to be the acute renal failure or the RPRA. HRCT thorax gives you the cavitary lesions or any kind of lung involvement. And if another age is very important, because some of this RPGN group, they are bimodal presentation, that is in 120 to 30 years of age group, and then again they recur in about the more than 70 years age group. So when the patient is above 50 years and with the rash, hemoptysis, or the proteinuria, we have to think of the possible glomerulonephritis. So this is actually the clue how will you go straight away for the diagnosis before you going for any kind of direct investigation or biopsy. Whenever you have just find out whether it is a maybe a cause for the RPRA for RPGN, you have to send for the serological test that you give as more prominent or more accurate diagnosis. When you will send the RPRA panel, that is ANA, ANCA, C3, C4, and also ASO titer where the PSGN is suspected, or the anti-GBM disease when the lung involvement is there, there is a hemoptysis is there, or sometimes in case of the systemic fluorosis, it may send to the anti-HCl70. So these serological tests should be done for all the RPRF or PGN cases to find out the cause, because we have seen many cases they have ANCA positive, maybe the anti-GBM titer is high, or it is a mix or the combination of the disease. So prognosis treatment protocol also depends upon the how the serological test comes into consideration. So another important thing is that when the serological diagnosis is done, whether it is a ANA positive, ANCA positive, or ANCA negative, so biopsy has to be done. As the patient is an active sediment, there is a rapid rise of creatinine, patient is proteinuria. So actual diagnosis comes from the histological biopsy, and you have to biopsy is indication when there is a rapidly progressive renal failure, systemic feature is there involving the rash, neuropathy, flu-like syndrome, pulmonary involvement, patient having a hematuria, subnephritic proteinuria, active urinary sediment of the low complement, or any kind of this serological marker in the form of ANCA, ANA, and anti-GBM or ASO is positive. So renal biopsy is a very crucial for the ultimate diagnosis for giving the proper therapeutic intervention. So, what is the biopsy normally that looks like in the case of the RPGN? RPGN or RPRF, whatever things, the crescent is the hallmark. And this crescent is basically that is formed by some extra mesangial or extra capillary exudations and the proliferations of the different type of cells, parietal cell, macrophage, and other cells as well. And it has very much looks like is a half moon separate this there, and it is a lot of parietal epithelial cells. There is a mesangial cell, fibrous cell, and these crescents are the different type. When the cellular element is there, it is called cellular crescent. When the fibrous element is called fibrous crescent. When the mix is there, we call fibrocellular crescent. Because crescent is a very important diagnostic clue for the aging of the disease, aging of the procedure, and also the finalize the pattern of the particular RPRF or RPGN, whether it is 100%, whether it is a segmental, whether it is a circumferential, whether it is a global, and whether it is a same variety or in the different variety in the different glomeruli, all have the clinical importance. And whether it is a presence of the inflammations, fibrinoid necrosis, along with the glomerular basement involvement. So light microscopy very clearly, this is the glomeruli, this is a tucked up glomeruli, and this is all the bound space, and it is actually the proliferation is the crescents. This is a classical picture of the anti-GBM glomerular nephritis with the large cellular crescents forming a gap over the glomerular tuft. So what is the RPGN? RPGN is the rapid loss of renal function, presence of the oliguria, and there is any kind of feature of glomerular involvement in the form of dysmorphic erythrocyturia, erythrocytic cylindruria, and the glomerular proteinuria. So there are a lot of discussion in the RPGN. I will just overview few of the patients who we actually came across very frequently in our clinical practice. That is the anti-GBM disease, immune complex mediated disease, and the post-immune crescentic glomerulonephritis. Because all these three actually comprise about the 90% of all the RPGN presented in our clinical practice. So when you will look for the RPGN, or when you will just at least think of the patient with the RPGN, that is a rapidly progressive glomerulonephritis with the rapid loss of the GFR. And most of the cases when they are presented, that is GFR is lost according to more than 50% GFR loss between the days and week. And hallmark is the crescent, and crescentic glomerulonephritis is actually the pathological hallmark to describe the RPGN. And it is the result. What is the crescent? It is the result of the focal rupture of the glomerular capillary wall that allows the inflammatory mediator and the leukocyte to enter the Bowman space, where they induce the epithelial cell proliferation and macrophage influx and maturation that together produce the cellular crescents. So this is a very beautiful picture for the presenting these things. This is the normal glomeruli. This is the capillary loop. This is the mesangium, and that is basically the parietal cell epithelium, and this is the Bowman space. So what happens actually whenever there is inflammation is there in the mesangial capillary involvement or in the vascular involvement is there. So some exudations, some stimulation comes outside of the capillary wall, and this actually starts or initiate the inflammatory cascade. And when the inflammatory cascade is there, there is a proliferation of the parietal cell, epithelial cell, along with the infiltration of the macrophage. So see, there is parietal cell is actually the starting unit gap in the multiple layer. And when it is processed and when the insult is actually continued, this is the multi-layered crescent has been formed, and all the vascular component, that is messenger, there is a capillary loop, is been compressed within a one bounded space. So it is looks like a very cap-like thing. So this is called the crescent. This crescent is the hallmark of the RPGN in a histologically. This is the light picture. If you see, that is the normal glomerular. But whenever it in the cases where the crescent is there, you will see the crescents. This is the cellular crescents, and some one or two fibrous crescents is there. This is the capillary loop. This is the normal glomerular. So etiologically, when the RPGN has been diagnosed, what are the basic cause for the RPGN? One of the commonest causes is the infectious disease in the form of the post-streptococcal glomerulonephritis, infectious endocarditis, and some systemic sepsis, hepatitis B and C infection, or rarely some cryoglobulinemia also is concerned. In some multisystem disorder like SLE, good posture, henoxaculin purpura, necrotizing vasculitis, even in the malignancy or relapsing polycandiditis, disease also may present as a kidney involvement in the MPGN or an RPGN like pattern. Some idiopathic group that is mostly come to the nephrologist, that is anticoagulant replacement membrane antibody disease, immune complex mediated disease, or post-immune, or mixed in the overlap of the disease. So they can present with this crescent and with the basic disease. So sometimes this present may be present with the crescent with the IgA nephropathy, crescent with the membranous glomerulonephritis, or there is a different variety of the crescent with the MPGN pattern. So all are actually included in the group of the RPRF RPGN category. Some drugs is also the increase the formation of the crescent in the form of there is a allopurinol, dipenicillamine, hydrolazine, or rifampicin. They may can involve in the crescent formation, or presented as a RPGN like picture and presented with the subnephrotic proteinuria, hematuria, and renal dysfunction. So another important part for the RPGN group, that is the age distribution. If you see the main three characteristic group, that is one is anti-GBM disease, one is immunocomplex disease, and the post-immune glomerulonephritis. In case of anti-GBM disease, there are all the percentage in the same category. So even in the younger age group and the elderly age group, all maintaining the 12 to 15%. But if you see the immune complex disease, mostly they are actually presented in the younger age group. 50% is a younger age group. But in case of the elderly age group, specifically in the women, that is post-immune glomerulonephritis. So whenever the patient is presented with the elderly age group, so it will be much more in favor of post-immune glomerulonephritis. But in the young age group, they are actually they are immune complex disease. So the histological classification, or in the proper classification, the RPGN is the type 5. That is one anti-GBM and immunocomplex, post-immune with ANCA positive, post-immune with ANCA negative, and in a combination, whether both in the anti-GBM titer is high and with the ANCA positiveness. So what is the histological classification? Histological classification depending the whether the crescents and the type of eye pattern. So how it will differentiate? Type 1 is the antiglomerular basement membrane. There is 100%, almost 95 to 100% patient. They are actually good posture syndrome, or sometimes when the lung involvement is not there, it is renal limited good posture, renal limited anti-GBM disease. Sometimes the patient is 50%, 20-50% of the crescent is there, and the different age of the patients crescents. So it is maybe a systemic lupus, IgA nephropathy, or cryoglobulinemia vasculitis. And some group crescent is there, but not some immunological insult. So they are basically the present with or without of the vasculitis. They are post-immune glomerulonephritis, and they are basically the idiopathic crescentic GET, Wegener granulomatosis, which is now is called the granulomatous polyangiitis, and also the macroscopic polyangiitis, glomerulonephritis. So how it categorized in the IF? It is very important for the both the nephrologist and the clinical care physician. That is, whenever the linear staining is there, if you see the line, linear staining is there for the IgG, and it is a diffuse, all this part is involved. So it is actually the anti-GBM disease. And when there's a granular, if you see very small granular, but this granular is a coarse granular is the PSGN, that is called post-septal glomerulonephritis. It's a granular pattern. And when it's a fine pattern, it's called membranous glomerulonephritis. IF is there. But if you see in compare between the two, intensity is very minimal. And if you see that is the greenness is very low. So it is scanty background staining. So it is actually the hallmark for the positive glomerulonephritis. So IF is very characteristic and can give you some clue the which group you are actually dealing with. So that is, I have told, that is when the lung hemorrhage is there, good posture. If it is not there, it is the typical anti-GBM glomerulonephritis. And another important part is that when there is a granular IF, whether it's a coarse or the fine, you can find out whether IgA is predominant, then it is called the IgA nephritis without vasculitis. But when the IgA deposit is there along with discretion, or the systemic vasculitis is there, is called in an elderly age, it is or age adult, it's called IgA vasculitis, or there may be in children, it is actually present on the henosculum purpura. And sometimes patient when low C3 with the ASO titer is high, with the background of the infection, they might give rise to the PSGN. Sometimes the membranoproliferative glomerulonephritis, that is very important for the diagnostic point of view. So which part is being actually involved for the trigger, whether mesangial or it is some deposition is there, subendothelial, intermembranous. So when is the deposition is there intermembranous, it is a specific category. It is called the MPGN type 2, or formerly it was called as the dense deposit disease. But when the subepithelial, subendothelial deposit is there over in the mesangial, so it is basically the classical MPGN pattern is called the MPGN type 1. And other group where the thickening of the basement membrane and always the subepithelial membrane deposit, it is actually the membranous nephritis with crescent, or some reticulotubular intrusions is there. That is in case of the SLE. So this is very important for the diagnostic point of view. But when IF is not so much significant, but there is some ANCA is positive, then you have to think of whether presence of the vasculitis or not there or not. So if the vasculitis is there, with or without granuloma and without asthma, basically it is called the GPA, that is granulomatous polyangiitis syndrome, or so previously it is called the Wegener. But when there is some present with the lung involvement, or P-ANCA is much more predominant, it is in the favor of the macroscopic polyangiitis. And when there is eosinophilia, asthma, or there is some 50-50, that is ANCA or the P-ANCA, but most probably in the P-ANCA possibility, that is but Chooks stress need to be considered. So few information about the good posture syndrome and the anti-GBM disease. It is account the 10 to 20% of the cases, and mostly the IgG is the deposition, and incidence of the anti-GBM disease is the bimodal peak, that is 120 to 30, and another is the 70 years. And there is a second peak much more common in the women group, and some genetic susceptibility is there. So you need to be very carefully consider when you are dealing with this patient. In case of the anti-GBM disease, like macroscopy shows, that is the 97% patient with the almost 90% of the patient, and they are maybe associated with the fibrinoid necrosis and the vascular involvement. And sometimes special stance is required to see the continuity of the basement membrane in the form of the Jones methylamine silver stain or acid chip, whether any breach or break in the continuation of the glomerular basement membrane is there. Because many of the patient, whether the continuation of the membrane or it is an intact membrane or it is a break or fibrinoid necrosis, give you the consideration of the your activity index, histological activity index, and that also the giving the clinical severity and need much more importance for the therapeutic point of view. So necrotizing glomerular lesions of the crescents is very much important in the histologically, and most severely injured glomeruli have the global glomerular necrosis, or maybe presented with the circumferential crescent or disruption of the Bowens capsule. So this is actually the picture how it looks like the anti-GBM disease. That is, I've shown you in previously, that is the vascular that is tough and all the crescents is there. Many of the patients are basically whole is there. So it is not the circumference, it is a comprise of the whole of the glomeruli. And if you see in the acid chip state, when the basement membrane looks like black and it is a intact, so there is no some breach or break in the glomerular basement membrane. So this is actually silver stain. They give rise to the presence of two important things. One, this is the vascular component, the fibrinoid necrosis is there, and but the involvement of the glomerular basement is intact. And this is another beautiful picture that if you see very carefully, very classically linear staining of the anti-GM, that's like a line. So it is very hallmark of the anti-GM glomerulonephritis. So this is whenever they are in the IF, it is looks like a green. So it is, and it is 100% of the glomeruli, almost 90 to 100% of the glomeruli involvement. Surely it is anti-GM disease need to be considered. And electron microscopy has immense value in case of the nephrology point of view to diagnose the subcategorization of the MPGN and also the pattern, which is very close, which is cannot be differentiated in the light microscopy. So if you see in this electron microscopy, this is the thing is the glomerular basement membrane, this is the vascular component, and this is the capillary wall, and this is actually the parietal cell, and then this is the Bowman space. So if you see in this group of cases, there is uh, some haziness. So it is basically the thrombosis in the capillary. And if you see very carefully, there is microscopically, it is that the straight line is there. And this is actually the component that is a clump out. So all the fibrinoid necrosis, and also there is some involvement of the endocapillary proliferation, and capillary involvement is there. So this is very important for the prognostication and also the actual diagnosis of the subcategory, whether it is a dense deposit disease, it is a C3 glomerulopathy, it is a MPGN of other variety, or it is a mixed variety. So it is called fibrinoid tactoid. So it is another look in case of anti-GBM disease. There's absence of electron-dense IC deposit with a distinct break in the anti-GBM disease. You see, this is the glomerular basement membrane, but its continuity is being breached, this break. So it is actually the bad prognosis, and it is the triggering crescentic formation. This breach actually when inflammatory cascades is there, and when the inflammatory beta neutrophils and other will go into the Bowman space, they will actually give some impetus for proliferation of the parietal cell, and this is the first things for the diagnosis of your formation of the crescent. So this is very important. And MPGN showing the very electrodense inclusions deposit in the subepithelial. If you see the subepithelial, this is subepithelial deposit and the subendothelial deposit, and this is very important for the categorization of the different type of the MPGN. So I am not going to the details in the pathogenesis, but the thing is that the anti-GBM antibody react with the non-collagenous domain, and the inflammation starts, and they actually giving rise to the glomerulonephritis. And this is very important. And this insult actually not on the anti-GBM antibody, they may be insult in the different of the genetical trigger, drug trigger, or some ANCA may be a trigger for some, no, it is a not so much, because possibly ANCA is much taking a major role. But in case of the combination of the disease, anti-GBM and the ANCA sometimes is both positive. ANCA also take part in destroying the glomeruli as well. So, what is the cause for the RPGN developing the crescent? When the GBM is ruptured, fibrin exudate comes into the Bowman space. There's a proliferation of the parietal cell, and leukocyte infiltration lead to the crescents. And clinical feature, basically they present with this three important clinical feature with the subnephrotic proteinuria, hematuria, and also there is a progressive renal failure. Sometimes patient may be present with the symptomic symptoms. And basically the smoker, and how another important is the lung involvement need to be addressed, whether it is a incipient lung hemorrhage or HRCT may be give rise to the anatomical and actual configuration. Sometimes hydrocarbon also give you some respiratory infection or protein-based mineral oils. They have actually think of whether it is a pulmonary hemorrhage is there or not. So it is how it is the pulmonary hemorrhage is there. It is a cut section. If it is the diffuse pulmonary hemorrhage is there, and if you see in the CT, it is all the lobes are being involved. It is a white space. So it is kind of very characteristic of the Goodpaster syndrome, whether the severe pulmonary hemorrhage is there. And this type of patient prognosis is very bad. Even in the intense immunosuppression and the plasmapheresis, the mortality is very high. So this is actually the pattern how it looks like the pulmonary hemorrhage in case of the chest X-ray. And laboratory findings, as discussed, that is, you have to check for the dysmorphic RBC and you have to check for the anti-GBM titer. That is very characteristic and the additional information whether you are dealing with the anti-GBM disease or not. But sometimes whenever you can get this anti-GBM titer is very high, you need to check another ANCA and other serological marker as well. You should not diagnose then and there, because many of the patient having the combination of the disease is there, because combination disease combined disease is much more better prognosis rather than the individual disease is there. So you have to very careful whenever the patient, and whenever even the histologically you can get the patients almost 90% definitely point towards the anti-GBM disease, but you have to find out the other cause as well. So treatment is the very straightforward treatment, needs very intense immunosuppression therapy from the very beginning in the form of corticosteroid, cyclophosphamide, and plasmapheresis is a hallmark. That is the anti-GBM, that is antibody need to be removed from the body, and plasmapheresis is basically 40 to 60 ml need to be removed. It is a 14 days of the therapy, either in the daily dose or in the alternate dose is there. But sometimes even in the in spite of very rigid plasmapheresis, sometimes response may not be very good, so you have to take care additional information or some newer drugs. So immunosuppression is a hallmark of the therapy, and if the patient having 100% of the patient, the in a adequate biopsy sample, so there is a very important decision. So whenever the patient having a pulmonary hemorrhage, deteriorating of the GFR, you have to take the treatment very first, and whatever the treatment is available. But if the patient is a dialysis dependent at presentation, at the 100% of the patient in adequate biopsy sample, and there is a no pulmonary hemorrhage, prognosis is so poor, the patient is very going to be ESRD. So immunosuppression and plasmapheresis may not be so much helpful. So don't initiate immunosuppression plus plasmapheresis. But all the patients should get some steroid advantage in the form of pulse methylprednisolone along with the tapering dose of the prednisolone, and that should be continued up to the 6 month of the therapy. And whenever the cyclophosphamide is a choice, it should be maintained in the orally 2 milligram per kg for the 3 month. And important, the what is the plasmapheresis failure? Even in the patient having a 2 week of alternative plasmapheresis, adequate plasmapheresis, there is no response. So it should not continue. You the there is plasmapheresis is will be ineffective. And that will be good, no benefit. So monitor, and you have to patient in the maintenance phase, you have to maintain the therapy. But sometimes even in the remission phase, the patient is relapse. In this type of patient, relapse is not so frequent. So if the relapse is there, treatment is simply the same as in the acute disease. Transplantation, the 6 month undetectable anti-GM criteria is the must criteria for going before the transplantation in this group. So another broad group is the immune complex. That is a very important, and many of our clinicians actually every day we check, we'll see this type of patient, and mostly there is a IgA nephropathy, post-infectious glomerulonephritis, and the MPGN pattern. And in the systemic variety, it is IgA vasculitis, SLE, and the cryoglobulinemia. And hallmark is basically immune complex deposit in the glomerular basement membrane, either in the outside or in the in situ formation, and damage the glomerular basement membrane, and ultimately lead to the crescent formation and the damaging the kidney. So whenever there is immune completion formation is there, we will give the complement. Complement is the two factor, either the complement hyperactivation or called altered complement activation or dysregulation of the complement. So all this pattern, when the immune complex is formed, they involve in the glomerular basement membrane, they involve the vessels and ultimately lead to the glomerulonephritis, and they form the necrosis and the karyodesis. That is very much clearly evident in the histological biopsy. So if you see in this patient, the immune complex glomerulonephritis, it is very looks like the anti-GBM, but the thing is that the crescent is very much confined to some part of the glomeruli. It is not the whole of the glomeruli is involved. It is not so, but 20 to 50% of the patient having the glomeruli having some crescent, the 100% crescent is usually not present in this group. And they are present in a very characteristic of the deposit. When the IgA deposit is predominant with the crescent, it is called the crescentic IgA nephropathy. When the main disease is the empygean, but presence of crescent, it is called crescentic empygean. When the patient having a low, high ASO titer, low C3 infection is there, and there is a crescent is there, it's called crescentic post-infectious glomerulonephritis. And when the thickening of the basement membrane, there's a spike, and along with this crescent, it is called crescentic membranous nephritis. So all the cases, whatever they involve immune complex, crescent is the hallmark of the RPGN. It may be present with the basic disease. So in this group of patients, if you go for the PSG and if you see, the staining is basically the granular. It's a granular staining, and the granular is very coarse granular. And all the predominant granular is the IgG1. And electron microscopy is the hallmark, is the deposit, where actually the position of the deposit giving rise to the which category of the immunocomplex disease is actually you are looking for. Whether deposit in the mesangial, that is in favor of the IgA nephropathy, it is a subendothelial, looking for the SLE, it is a intramembranous, it is for the dense deposit disease, or MPGN type 2, it is a subepithelial, it is a much more membranous, or in a combination. So position of the deposition is very important, and to address which is the basic disease for which the RPGN is actually taking place. And I'm not going to detail the how the immune complex actually affect the glomerular basement membrane and initiate the crescent formation. Basically, they involve the humoral mediator system, activate the coagulation system, kinase system. They altogether comes, and they in the influence of the drug, toxin, and gene, and also the altered complement activity, they actually give rise to the vascular component necrosis and the glomerular component injury. And there is a two important part, there is the endocapillary hypercellularity and the extracapillary hypercellularity. When the insect is within the capillary wall, there is a capillary endocapillary proliferation, there is a fibrinoid necrosis. This is within the glomeruli, so it is called endocapillary hypercellularity. But when there is a breach is there, basement membrane is actually disrupt, and when the cell is come out and there is epithelial involvement there, it is called extracapillary hypercellularity. Prognosticate is a histological findings. So this is actually the how the pathogenesis take place. Regarding the treatment of the immune complex glomerulonephritis, almost the same. That is start with the pulse method penicillins. That is 3 day followed by the tapering prednisolone. And the third group, that is another important group, that is a post-immune crescentic glomerulonephritis, which is very important. They are sometimes present with the vasculitis, and immunocomplex is sometimes it is not there. IF is not so strong and prominent, and this is actually called the post-immune crescentic glomerulonephritis, and is a component of systemic small vessel vasculitis, and it is the most common category of the RPGN in adult. And especially in the older adult, there is a predictions where the white compared with the black. So this is a very beautiful picture, and if you many of us actually very familiar with this classification. This is a vasculitis classification. It's a large vessels and it's medium vessels, the small vessels, and the capillary wall. And if you see, that is the almost all pattern. There's medium to small vessel, including the capillary. They actually involve this uncorrelated vasculitis in the form of either microscopic polyangiitis, or it is a GPA, that is granulomatosis with the polyangiitis, or maybe a Chukstov syndrome. So I'm not going into detail in the vasculitis characteristics, but how this uncorrelated vasculitis looks like in the light macroscopy. So it is indistinguishable from the anti-GBM disease crescentic GBM, because all we have seen there are some glomeruli and some necrotic component and also the crescent. And even in the renal limited possible crescentic also indistinguishable in IF. So it has been distinguished by the electron microscopy, serological marker, and along with the other urinary biomarker. So what is important between the two? That is approximately 90% of the kidney biopsy specimen with the ANCA associated possible glomerulonephritis have some degree of the crescent, and there must be focal, segmental, or global fibrillary necrosis. So that is actually give rise to very much clue to the ANCA-related vasculitis, and there is some arteritis along with these things. And if you see this, it is a very beautiful picture for this ANCA-related vasculitis. If you see, in this case of glomerular basement membrane is intact. In the capillary wall, there is some fibrinoid necrosis is there. So these are smudgy lesions is there. So some cellular element is not there. So it is a called fibrinoid necrosis. And some crescencies also is there. Some crescencies also there. So this is very typical of the crescentic ANCA-related possible glomerulonephritis. And immunomicroscopy is the hallmark. IF is the absence of the glomerular staining in the immunoglobulin. And there is irregular staining of the fibrin. And when the patient sometimes is ANCA positive, sometimes it may be ANCA negative, but in some fewer percentage in the cases. So this is the ideal picture how it looks like in the IF in the ANCA-related vasculitis. So it is a very black background. It is not staining is not prominent. So scanty background staining is a hallmark of the possible glomerulonephritis. And another important thing is that you have to be very much careful with this how and type of inclusions and the position of the inclusions in the electron microscopy, even in the light microscopy as well. So when the specimen is the possible glomerulonephritis, electron dense deposit is very much important. Why it is there? It is a subepithelial, subendothelial, or intermembranous. And uncorrelated vasculitis in the pathogenesis, I am not going to detail. The basic thing is that the antibody that is formed against the neutrophil, either in the neutrophil inclusions body or some other inclusions body. And if you see in a characteristics, if you see there may be some trigger point is there, infection, drugs, toxin, and some genes involvement is there. Some trigger point is there. There's some antibody is formed called ANCA. ANCA is a itself a pathogenic, and this ANCA antibody, there is anti-neutrophilic cytoplasmic antibody that is comes into the neutrophils, and the inclusions body they are actually externalize the surface. They meet together, and the respiratory burst and all the neutrophils becomes actually burst, and all the inclusions came out, and that is actually the insult or the initiation of the complement cascade and the inflammatory cascade, and that typically that lead to the vasculitis, fibrinoid necrosis, and also the glomerular injury that lead to the crescentic glomerulonephritis. So ANCA is itself a pathogenic. That is very important. So ANCA titer need to be addressed, and that maybe sometimes it is also giving the prognosis of the patient. So in case of the possible vasculitis, there are three main categories: Wegener, Chooks stress, and the macroscopic polyangiitis. Most of the cases there are necrotizing vasculitis is there. There are medium to small vessel vasculitis. There is a PR3 ANCA positivity is almost 70 to 80% is of the GPA, granulomatous granulomatosis and polyangiitis. And there is the previously it is called the Wegener granulomatosis. Involvement is there with the sinus and the respiratory, or there may be associated with the lung involvement as well. And macroscopic polyangiitis, basically their P-ANCA, that is the myeloperoxide positivity is much more there. C-ANCA positivity only 20 to 30%, mainly involvement in the lung, and also they are associated with the necrotizing vasculitis as well. And choke stress is a very characteristic in the form of the bronchial asthma, eosinophilia, and also the either C-ANCA or P-ANCA are both in the positivity of 20 to 30%. But this is maybe present in some granulomatous lesions, and it is very important for the diagnosis as the therapeutic point of view. So this is actually how the systemic involvement is there in case of the oncolytic vasculitis. Kidney is much more involvement in the microscopic polyangiitis. Lung involvement is much more in the vaginal granulomatosis, and skin involvement is much more involvement in the eosinophilia and rest is the Chuksa syndrome. And regarding the ANCA positivity, vagular granulomatous is the more than 70%, microscopic cholangitis is almost the P-ANCA is much more preponderance, and Chukstras is the much more preponderance. And possibly when it is as a total, the P-ANCA is much more preponderance than the PR3 positivity. So clinical feature of the oncophysicitis is the almost the same thing, sometimes limited to the kidneys, and sometimes is also the involvement in the external manifestation is there. And sometimes they are present in the pulmonary renal syndrome or dermal renal syndrome or involving the multisystem disease. And sometimes the patient involving the joint central nervous system, nerves, GI tract, and skin. And as the treatment is not done, so there's a multiple involvement can be manifested in the same time. So sometimes present is a present with the very mild symptom like fever, fatigue, myalgia. So that may be a clue for this serious disease. So laboratory finding is a very important, crucial. 80 to 90% patient have the ANCA positivity, and that is the P-ANCA, C-ANCA positivity is persistent according to the disease activity, and that need to be monitored for the therapeutic response and the relapse cases. So how it looks like the C-ANCA pattern? If you see, that is the neutrophil, and if you neutrophil, this is cytoplasm, and all the prominence is there in the cytoplasm. And if you look very carefully, this is the bilobe nucleus, but the stain is actually aggregated in whole of the cytoplasm. So that is called the cytoplasmic anti-neutrophilic cytoplasmic antibody. So this is the actually the classical pattern how it looks like in case of indirect immunofluorescence. And the same thing when is a P-ANCA, that is called the perinuclear anti-neutrophilic cytoplasmic antibody. If you see very carefully, that is if the whole of the neutrophil, the this is a bilobe nucleus, and the in concentrating the nucleus, there is some accumulation of the staining. So that is called the perinuclear, and this is actually how it looks like in a lab. So another important thing is that ANCA positivity can also have some predictive value. So if the renal failure, if the renal is much more severe, ANCA positivity will be the much more severe. It is about 84%, and 60% when the creatinine is 1.5 to 3, and 30% about this is a 1. So it has some kind of predictive value of the severity and the ANCA positivity. So more than ANCA, more is the serious is the disease, and more is the renal deterioration. And urine finding is very important to find out the cell cast, proteinuria, and is associated other findings of the sepsis. And kidney biopsy is the hallmark. You have to do the biopsy. You have to check for the crescents. And regarding the treatment of the oncolytic vasculitis, there are very they change time and again. Even if you see the trials, they have shown whether benefit of the immunosuppression, benefit of the cyclophosphamide, benefit of the plasmapheresis of the combination therapy, benefit of the rituximab. They have lot of trials in the multicentric trial, but they are not established particular trial that is really the only one drug that can be addressed all the course of the disease and can stop the disease or halt the disease anymore. So if you see from the 1990, there is regarding the plasmapheresis and the immunosuppression was started like the hallmark trial, the Cyclogeram, Mapex trial, and next the Cyclops trial, Improve trial, RAVE trial, Rituximab trial, Mainstream trial, all basically the whole trial, they have shown some kind of benefit with the plasmapheresis, some shown in the some benefit with the rituximab or in a combination therapy, but still it is a really challenge in a case of refractory oncovascular group of patients. The last trial that is very much uh, breaking trial is called Pixivas trial. In the Mapex trial, that has been shown benefit of the severe form of oncocerebral vasculitis, even the pulmonary hemorrhage, with the plasmapheresis benefit. They have doesn't show any benefit in the plasmapheresis or any good for the plasmapheresis in the Pixivas trial. Though there are a lot of debate in the trial whether the plasmapheresis is good for the very serious disease of the hemorrhage, but still it is a practice whenever the severe hemorrhage is there, uncorrelated vasculitis, patient is deteriorating, the patient is not improving, plasmapheresis is really a first choice of the therapeutic procedure. So this is the way. I'm not going to detail the trials, and these all the trials have some advantage and disadvantage, but the take home message is that still the uncorrelated vasculitis is really a challenge for the nephro physician and also the pulmonary care physician as well as the clinical doctors as well. And there is now they are very much fond of looking some cocktail-like therapy to giving some cyclophosphamide, some plasmapheresis, and also maintaining tapering dose of cyclophosphamide regarding the biopsy, regarding the how much IFTA, that is the interstitial, there is a glomerulosclerosis or the in tubular atrophy or the interstitial fibrosis is there. So whether the revivability is there, whether the patient can be come down to the previous level. So this is the cocktail therapy. So what is the current guideline of the uncorrelated vasculitis? Is very important because many of our patients they are come to the medicine people or in the nephrologist when they lost in follow-up. Sometimes they are not taking the treatment or they stop in taking. So what is the protocol current guideline? That is in case of life-threatening vasculitis, steroid and cyclophosphamide is the mainstay of treatment. Cyclophosphamide should be given at a dose of 50 milligram per kg body weight, a maximum 1.2 gram every 2 weeks for first 3 pulse, followed by every 3 weeks for next 3 to 6 dose. And dose adjustment will be required according to the age and the GFR. That is very important. And another important is how it is very important for the internist to know how will you give the cyclophosphamide when the cyclophosphamide is actually. So you are actually consider the patient for the cyclophosphamide, you should uh, uh, give the consent. You should discuss with the patient regarding the fertility sperm banking oocyte. In case of the patient, female patient, we have to give some GNH analyze to for the ovum concern, and we have to give a cotrimoxazole, and you have to check the parameters. You have to give to the prophylaxis. Some most important part of the cyclophosphamide administration is that you have to give the big vessels. That is a big board vein. Otherwise, there will be some maybe a necrosis or thermophlebitis, very common. And sometimes Misna is required, sometimes Misna is not required. So you have to be careful about the your institutional protocol. And steroid should be given in the pulse methylprednisolone followed by the tapering of the prednisolone. Rituximab is the choice where the cyclophosphamide is contraindicated or not indicated. So 375 milligram per meter square is very important for the 4 dose. Majority of the cases is improved. But sometimes the relapse is there, then plasmapheresis is indicated. The same protocol for the plasmapheresis, that is indication the patient having dialysis, rapidly progressive renal failure, and creatinine more than 5.6, and patient with the active pulmonary hemorrhage. And how it will do? And vascular titer is very high and in the Wallop syndrome. And how it will do? That is 60 ml per kg volume replacement is there. 2 weeks is the adequate dose, and associated with anti-GBM is there. Then you have to much more aggressive plasmapheresis is required daily for 14 days. And very important take home message, patient who remain dialysis dependent and who do not have any external manifestation of the disease, discontinue the cyclophosphamide therapy after 3 months because there is no hope of recovery. And if any patient, if that is the external manifestation is there, so in spite of there, you have to continue the treatment. Otherwise, external manifestation will be the flare. So this is very important take home message for the who actually practicing treating this group of patient. And how the maintenance therapy, when the remission is achieved, either in the biomarker or histological remission, and so then, and the Viva score is less than 1, penicillin should be continued for less than 10 milligram per day regarding the consolidation. And it should be continued in the form of azothioprine, or where the azothioprine is contraindicated, methotrexate can be given as a maintenance therapy. And what is the treatment of relapse? Treatment of relapse almost the same because relapse is very frequent and you have to treat the treatment as well on the first things. What are the risk for relapse? That is the when is PRA Anka is much more higher percentage with the MPO ANCA, history of upper respiratory involvement, and there is some cavitary lesion of the active pulmonary hemorrhage. They are very much prone for the relaxed flow. And what is the treatment of the severe relapse? The same things with the plasmapheresis and the cyclophosphamide, and maybe use of the rituximab or the newer drugs like avocapan or some anti-April anti therapy. Who was who had not take the relapse, treatment for not severe relapse with the immunosuppressive therapy should be increased. There must be agiotherapy in a MMF, maybe in a alone or in a combination, and IVIG may be involved in case refractory group of patient. And what is the ANCA level monitoring? ANCA level monitoring is important to check the diagnosis point, whether in a remission state, patient whether in a relapse, or patient need to be change of therapy, or patient actually waiting for any transplantation. So what is the indication for the transplantation? Delay transplantation until the 12 month of the remission phase or quiescent stage. And don't delay the patient in a who is already ready, but ANCA is positivity. So ANCA positivity may not the contraindication for going for transplantation workup. So in final slide, the prognosis depends upon early treatment crucial to preserve the renal function. Untreated possible patient, 80% is the mortality rate. 25% progress to ASKD. Relapse rate is very common, about 40%, but anti-GBM relapse is rare. Poor outcome, patient in a high creatinine at the presentation, patient having a long dialysis, anuria, pulmonary hemorrhage. And regarding some recent advances, they came forward for this treating of this group of patient. That is anti-BF, anti-therapy, belimumab, atolisib is much more important. Pixibus trial, though limited role in plasma, but it is very important. Emerging biomarker is actually urinary SCD 163, MCP1 also came into practice, but in a very laboratory level. Personalized treatment, individual approach is the mainstay of treatment. So, in nutshell, one of the patient having comes with the clinicians with the suspected case of the RPRF or PGN, go for history and clinical examination and initial workup to see the routine CVC, urine, check for USG, and if it is there, go for serology. If it is positive or negative, do the biopsy, check this whether biopsy patterns, UF pattern, and categorize the group of patient and treat accordingly. Thank you.
Thank you, Dr. Pinaki. I think you have done a wonderful job. I think it's more of actually for patients with the nephrologist rather than for the general physician. But in any case, you have depth in the in-depth analysis of so-called ANCA associated or the vasculitis associated with rapidly progressive glomerulonephritis. And this is a wide area. And the suspicion, as I said in the beginning, suspicion is more important. And once you suspect, you have to check the biomarkers and then finally get the diagnosis if necessary by biopsy. See, if you, finance is not a concern. For example, I'll tell the name. See, if a patient, if you find the patients who are coming from the CMC Vellore, and then they do all the testing for all the patients, like ANCA and then ANA profile and so on. So we should have at least patients who presents like a glomerulonephritis like picture. They should have all these serologies if possible. Yes, I think if there is a provision question answer, we can go ahead. Is there a question in the chat box? Dr. Karmakar, Dr.
Yes, sir. There is. I have gone through the chat box. There is
Yes.
no question
Okay.
right this
Okay.
moment.
Okay.
Probably it has been so lucid that
Yeah.
no one is getting any confusion.
Yes.
So,
If
Dr.
necessary, you
Ganguly is
can
there
close.
for concluding
Yes.
remark.
Yes,
Dr.
I'm
Ganguly,
here.
over to Dr. Ganguly. Yeah.
Yes, I'm here.
Okay, please, for your concluding
Ajab,
remark and vote of
I
thanks.
must congratulate my bosom friend, Professor Dilip Pahadi, the best students of our batch, and Dr. Pinaki, my student. They have a very wonderful lecture of this rapidly progressing renal failure. This is our problem, both in general medicine, also for the rheumatologist. So early intervention and full knowledge, especially the clinico-pathological correlation, will definitely help us to take the adequate measure, and we can survive some of the patients suffering from this rapidly progressive renal failure. Thank you to the chairman and also to the speaker for their wonderful job.
Thank you, sir.
Okay, thank you.
Thank you, everybody. And a special thanks to Dr. Pinaki Mukherjee and Dr. Pahari sir for giving this time for this masterclass of the PGTs. Thank you.
Thank you.
খুব ভালো হয়েছে পিনাকি,
Thank you.
খুব ভালো হয়েছে।
আসলে this is a very difficult
না না
topic and
ঠিক কথা,
actually
না না খুব সুন্দর
একটু
হয়েছে, খুব lucid। থ্যাংক ইউ।
Thank you.
পরে দরকার
Sir,
হলে
should
আবার
I leave?
বলবো।
Thank you.
Yeah, you can leave.